Hello, everyone, and welcome to the I-STARR webinar series. I-STARR stands for Infrastructure for Studying Treatment and Addiction Recovery Residences, and the I-STARR project aims to develop infrastructure to advance science on recovery housing, particularly recovery housing for persons treated with medications for opioid use disorder. Today, we're so fortunate to be hearing from Maria Paschke, Rachel Davidson, and Lindsey Pawlowski, who will present on peer respite housing. And they will share findings from a project, a pilot program involving 5 respite crisis stabilization programs in Missouri, focusing on residents' recovery experiences and housing stability. So if you've been to one of our webinars before, you'll remember that the I-STARR project is supported by a grant from the National Institute on Drug Abuse, and it's part of the larger NIH Helping to End Addiction Long-Term or HEAL initiative. So it's one of several projects that comprise the Consortium on Addiction Recovery Science, or the COARS network. So just some quick housekeeping rules about the format of the webinar. All audience members are currently muted, and we encourage all attendees to use the Zoom chat function to introduce themselves, connect with fellow audience members, and to ask questions of our presenter. We do have an I-STARR project member monitoring the chat, and we will unmute audience members after we hear from our presenter, so that the attendees can raise their virtual hands and participate in the discussion at that point. Also, this webinar and each webinar in this series is being recorded so that those individuals who are unable to attend today will be able to learn from it. And finally, a reminder that closed captioning of this webinar is available within Zoom, and you can find it using the functions at the bottom of the screen. Next slide, please. I am Carmen Masson. I'm a faculty member at the University of California, San Francisco Department of Psychiatry and Behavioral Sciences. And the I-STARR project is co-led by Doctors Amy Miracle at the Public Health Institute and me. The team also includes co-investigators Sarah Zemore and Lenny Jason, biostatisticians Meena Subbaraman and Libo Lee, and communications specialist Diane Schmidt, and the team's project coordinator Quinoja Capitani. Next slide, please. The I-STARR project is guided by an amazing 17-member advisory board that's comprised of diverse leaders from across the country. So our advisory members represent recovery and recovery housing leaders, treatment providers and payers, national policy
It's tomorrow.
as well as researchers and educators. Next slide, please. So let me tell you a little bit about our presenters today. Maria Paschke is the Director of Impact and Innovation with the Addiction Science Team at the Missouri Institute of Mental Health at the University of Missouri, St. Louis. She serves as the lead evaluator for a portfolio of academic and community research projects focused on expanding access to low-barrier overdose prevention, treatment, and recovery supports. Her work includes initiatives such as an EMS-administered pre-hospital buprenorphine program, transportation assistance to improve linkage to care, local street outreach coordination, and peer respite crisis stabilization housing. Now, Rachel Davidson is the Chief Executive Officer of Ozark Recovery Housing. In this role, she oversees the organization's strategic direction, operations, and community partnerships while advancing its mission to provide safe, recovery-oriented housing and peer support services to individuals affected by substance use disorders. Lindsey Pawlowski is the Recovery Services Project Coordinator and Community Engaged Research Lead with the Addiction Science Team at the Missouri Institute of Mental Health at the University of Missouri, St. Louis. She works with the Missouri Department of Mental Health to evaluate recovery support services funded through the State Opioid Response Grant. So without further delay, let's turn the presentation over to Maria, Rachel, and Lindsey. Thank you.
Hi, everyone. Thank you for that introduction. Welcome, and thank you all for being here. We're really glad to have the opportunity to present this important work. To start, we're going to give you a little context about our organizations, and then we're going to jump into the model and what we're learning. We have packed a lot of content, so we're going to be talking fast and hopefully getting through as much as we can today. So next slide. Lindsey and I are joining from the addiction science team, which is part of the University of Missouri St. Louis and is a collaborative team between the Missouri Institute of Mental Health and the Department of Psychological Sciences. We are the naloxone hub for the state of Missouri and promote effective and compassionate responses to substance use through distribution of supplies, training and education, and advancing research to inform responsive, evidence-based policies and practices across prevention, treatment, and recovery. And I will turn it over to Rachel to tell you a little bit more about Ozark Recovery Housing. Next slide.
Hi, everyone. I'm Rachel Davidson, and as we already mentioned, I'm the CEO of Ozark Recovery Housing. Ozark Recovery Housing is a respite and recovery housing provider in the Kansas City metropolitan area. We actually got started in 2019 in Columbia and then expanded to Kansas City in 2021. And it was born out of need, like most things are, right? So the original founders of our program are a physician and a nurse practitioner, and they were treating people with substance use and alcohol use disorder. And a consistent theme that they were constantly hearing from their patients was that there was a lack of safe, supportive housing that was focused on evidence-based modalities and allowed for all levels of MOUD, and it didn't have a faith-based element. So they wanted to bridge that gap and provide that housing for their patients.
Thank you, Rachel.
Next, sorry.
Sorry, next slide. So now that we have a little bit more context about who we are, we want to turn to the why behind this work. So we're going to talk briefly about kind of the need for peer respite within the system and the gaps in the current continuum of care that this model is designed to fill. So before I jump into that, I want to briefly situate you in what our peer respite model broadly looks like. So Peer Respite Crisis Stabilization is a voluntary short-term overnight program that provides community-based non-clinical crisis support to help people find new understanding and ways to move forward. It operates 24 hours a day in a home-like trauma-informed environment. So next slide. Peer respite is designed to meet the needs of those in early recovery. So sometimes our field describes these individuals as hard to serve, but the bigger issue might be that our system is hard to access at the exact moments that people need it most. So some of the critical gaps that we see where folks often are falling through the cracks is when there's a return to use. When someone is ready to make a change, but maybe there isn't a bed or a service available and they're waiting at that exact point of time, or when someone's maybe turned away because they don't meet eligibility requirements, in particular, a specific length of sobriety or having come out of a certain program. So this can leave people unhoused, unstable, or without really an appropriate service option to help them start to build recovery resources in that moment. So these are precisely the moments when people need an option kind of designed around potential recent use and not exclusion because of it. Next slide. So what impact does this have? This isn't really about whether somebody gets served eventually. timing matters. So when we miss that critical window, we may lose the opportunity to work with somebody altogether. And obviously that can lead to increased morbidity and mortality, which when we're not able to intervene or support folks. And the consequences show up across the system. It means that people are instead engaging and relying on emergency systems such as first responders, ERs, the criminal legal system, which we know are more expensive, and we also know don't always actually meet the needs that people are presenting with. And this builds more strain and burnout on our system. Our frontline staff who are working with people every day, it wears on people to see people fall through the cracks and for there not to be an option for them. Next slide. So throughout our presentation, we're going to be sharing some quotes from Peer Respite participants. We are in the middle of a qualitative interview project, currently conducting interviews, but we thought it was important that we were sharing the voice of people who have been housed through Peer Respite programming. So without respite, I wouldn't have had anywhere to turn. At the height of my fentanyl addiction, I was facing intense withdrawal symptoms before the treatment medication could even begin to help. Respite was the lifeline that started my recovery journey. I have no doubt without them, I would have had my final overdose long ago. I wouldn't be here today. So with that quote, I'm going to turn things over to Rachel, who will be kind of jumping in throughout the presentation to kind of give her perspective as a provider. What gaps are Peer Respite Crisis Stabilization housing designed to fill that traditional crisis and recovery services may not address?
I think one of the biggest gaps that Peer Respite Crisis Stabilization fills is the space between levels of care. So sometimes we see someone who has a meaningful period of recovery and then experiences a brief return to use or recurrence of symptoms. That person may not need to start their recovery journey over. And sometimes they simply need a safe space to step away from outside influences, reconnect with support, and stabilize before continuing forward. We often see people coming out of detox or very short hospital stays who may have technically be ready for discharge, but aren't necessarily ready for independent living, employment, or recovery housing. A few additional weeks of stabilization, structure, and peer support and connection to resources can make that transition much more successful. We also serve as a bridge for people who are waiting for treatment or recovery housing. And some may be motivated and ready for help today, but the appropriate placement isn't available until next week. And so that gap can be an incredibly vulnerable period, and we're able to fill that gap. We can also help remove some of the practical barriers that prevent people from accessing other services. Sometimes they don't have insurance or identification, other documentation required for benefits, treatment, or recovery housing. And during their respite stay, we have time to help address those barriers while they're somewhere safe and supported. There are also people who've been through traditional treatment before. For whatever reason, they aren't willing to try it again right now. And Peer Respite gives us another opportunity to engage that person rather than only having the options be treatment or nothing. Next slide.
Thank you, Rachel. So now that we've talked about why this is needed, I'm going to dig a little bit more into what this looks like in practice within our Missouri model. So in 2023, the Missouri Department of Mental Health awarded funding to establish 5 peer respite crisis stabilization pilot programs across the state to help fill this need in our current system of care for individuals in early recovery from substance use disorder. You'll note that this is kind of a range of communities. So we have St. Louis and Kansas City represented, but also a house in Branson, which is like a small rural community. And then in Columbia, which is a small city that houses the main campus of the University of Missouri. So providers applied to receive funding through the state opioid response grant. And the pilot has kind of wraparound support built in. So the providers meet monthly with the state and with our team for technical assistance and for information sharing. And there's kind of built-in research and evaluation and support to make sure that this is successful. Next slide. The model has 3 important components, which thankfully we put all right into the name. So Peer provides the human connection, both one-on-one and in groups. Support from people with lived experience is kind of an expectation of this model at each of the sites, that there's peers who are, available and working to be in the house and directly supporting people. Respite, this is an overnight, safe, comfortable place for people to stay 24 hours a day, where people's basic needs and meals are covered. And it is not a clinical environment, it's a home-like environment. And then finally, crisis stabilization. So this is a short-term stay. There's a max of 30 days. And it's for people who need a little time or a little structure. And so it's serving as a bridge to stabilize people and to connect to further supports, further resources, further programming to continue on a longer path of recovery. Next slide. Our model has two main kind of philosophies of care. So one is low barrier access. So it's really important to us that people are able to access the service without a lot of red tape. This means accessible intake hours, a flexible welcoming intake that minimizes kind of the forms and paperwork and length of time up front, accommodations for recent substance use, open door re-engagement after discharge, and gentle transitions when people are coming out, when they're ramping into more programming and structure, and then when people are discharging into their next step. Similarly, self-determined service engagement. We really focus on person-centered care, so self-guided planning, which involves people's recovery and treatment next steps, but also holistic resource integration. So like Rachel mentioned, making sure that people are connecting to a primary care doctor, getting their benefits in order, and kind of be able to prioritize what they think they need to be able to stay stable and maintain recovery. Next slide. So how does peer respite differ from traditional recovery housing, which I want to recognize there's a lot of different models and a wide span of what traditional recovery housing looks like. One of the main things is it's designed to be a short stay, as I already mentioned. So you can see on this graph, which shows the first 2 years of our peer respite data, that the majority of folks stayed 4 to 10 days. 2/3 of people stayed 15 days or fewer. So really, the majority of people are staying about 2 weeks or less. And that is a big difference between many other kind of sober living or recovery housing options. Next slide. Some other kind of quick distinctions is, as I already mentioned, kind of the low barrier, no prerequisites for readiness. One resident said, respite is the only way I would have gotten in. I had no idea where to even start. So, many people have recently used, and that is sort of built in, or there's accommodations for that. Withdrawal supported entry. So relatedly, programs knowing that there's options for people to, navigate withdrawal, whether that's connecting to a physician, having, over-the-counter comfort meds. I've never gotten clean before, so I was scared, but they walk you through the process. And then reduced outside influence. So most of the programs are fairly structured. This participant said, I was away from the outside world for 14 days, couldn't go outside, couldn't smoke a cigarette or none of that. So it was self-time. And they were saying this is a positive way. So this is kind of a protective environment where people aren't leaving the house to go on social calls or to kind of like stay in their normal life, but are really focused internally in the house and in getting their affairs in order and starting to engage in structured programming toward their wellness. Next slide. So how does peer respite and recovery housing work together? So really, our pilot is functioning in many ways as an explicit gateway into recovery housing. So it doesn't operate in isolation from the broader recovery kind of care network. As you can see in the graph, about 60% of people in our first 2 years were discharged from peer respite directly into recovery housing. And the time people spend in peer respite helps them build the foundation for success in recovery housing. So, by identifying and maintaining a recovery pathway during that time, that's working for them, and then addressing these basic needs. This all sort of builds a foundation of stability that they take with them into that next step and increases the chances that they're going to be successful. So they're kind of not just entering a bed, but entering with more resources. And many of our agencies operate both peer respite and recovery housing. So many of the residents we've talked to kind of noted that there's some continuity where they're able to stay in relationship with the staff and peers from their peer respite, and that they felt like those connections of not having to fully start over, but being able to maintain some continuity was really helpful for them. Next slide. So another quote, peer respite isn't a program like any other I've heard about. It isn't faith-based. It isn't strict with rules that say here is a path that everyone has to follow just exactly the same, because it's the only way to heal or recover from addiction. They understand as humans, we face addiction for many reasons and from many walks of life. It makes sense that there won't just be one formula. There's an outline and a baseline that begins with community, respect, safety, and care. They encourage and understand we are adults and we will walk our own journey in our own way. Whether we stick to sobriety or not, it comes down to choice, and that is ours. It's a beautiful place, and for me, it boosted my confidence and helped me choose to keep walking towards sobriety. No one forced me, no one shoved a God down my throat, and I was never in a place where I felt I didn't control my own life. Next slide. So, Rachel, can you tell us a little bit more at your site when someone first arrives at Peer Respite? What do you hope they experience that might be different from other systems that they've interacted with?
So yeah, absolutely. And I wanted to bring attention to the fact that this is our actual living room at our respite center. On any of the slides where I'll be speaking, the photos are photos of our respite center. So we hope that it's as welcoming as it is to us. When they first walk in, more than anything, we want them to know and experience a sense of belonging, and that they are welcome and that they can come to us truly as they are. It doesn't matter what their substance of choice is, their background, socioeconomic status. They don't need money, insurance, identification, food, clothing, any of it. They can come with nothing. They can be actively under the influence. Our screening process and eligibility requirements are intentionally very simple. They need to have a substance use disorder, have used drugs or alcohol in the last 30 days, and be able to safely coexist with other people in a shared living environment. So, I mean, I guess it boils down to they need to have a problem with drugs or alcohol and want to do something about it, at least right this minute. I guess that kind of like leads into the next question. I'm kind of like molding the two, but so low barrier in practice, right? We try not to make people prove that they're worthy or prepared enough to receive help. We're just willing to help them right now with whatever, wherever they're at. And that goes into our intake process. If you go into a traditional treatment center, out of necessity, there's lots of assessments and things that they do. And I'm absolutely not knocking that. But the unique thing about respite is that we don't have to do any of those things. We do what is immediately necessary. A lot of times people come in our door and they're exhausted and overwhelmed. They're anxious, they're ashamed, they haven't eaten, they haven't showered. Their physical needs, and meeting those gets to be our primary focus. So we collect their basic information, a urine drug screen, vitals. We make sure that they've signed the necessary consents, and then we focus on them. We introduce them to the other participants. We show them where they can put their belongings, if they have any, and where they can lay their head. So if what they need most in the moment is a shower or sleep or something to eat, we take care of that, and everything else can wait. So, one comment that I had, yes, most of us as respite providers are also recovery housing providers. And I know that what Maria was saying wasn't that is mutually exclusive, but I do want to note that, like, and I'm sure that other providers are like this too, we pride ourselves on being resource experts. We are familiar with all of the recovery housing providers in our area so that we can make meaningful referrals. We don't just use respite as a pipeline into our program. We use it to help them get connected to any program and the program that they choose that might be best and right for them. Next slide.
Thank you for clarifying. And now we are going to pass to Lindsey, who's going to talk about our initial outcomes from the pilot.
Yeah, so I'll just go over what we've collected in the first year of this pilot program, first 3 years, excuse me. And so, like Maria mentioned, this is a new model of practice. So we wanted to have a format where folks were learning from each other. So that included a monthly provider meeting with the Department of Mental Health and us, in which providers could share updates, successes, and implementation problem solving. For example, Rachel attempted recently to go non-smoking at Ozark and was like, what do we do? Have you ever done this before? And use that space to get some feedback on what that would look like. Ultimately, that reverse course, but Rachel may talk about that a little later. And so this is like where decades of combined experience is in the room to iteratively work on policies that stay true to the model, but address those daily implementation challenges. And we want our operators to be partners in evaluation. They are driven to share on and report on this model in order to improve integration of respite into the care continuum and advocate for further support and funding in their communities. And some of those examples included developing new reporting metrics that not only satisfy grant requirements, but also reflect on what success looks like and within the capacity of their staff, and attempting to be as low barrier as possible and not focusing, having a long intake at the beginning for participants. And we do have the qualitative interviews that we've planned with the providers that we are interviewing former participants, and we'll use that to identify what works and what doesn't, and share the outcomes that are not measurable in simply numerical data. Next slide. So overall, there's a steady year-over-year increase in how many folks were housed, hitting just over 1,600 in the third year. And of course, growth is not unlimited with, only 5 providers, and it depends on capacity at each location, but it's exciting to see it expand into the community and serve more people. Next slide. So one of a couple of pieces of information that we did want to capture in the data was basic information about incoming participants to understand what are the presenting needs. So almost half of participants were unhoused prior to entering respite. 57% reported having a mental health disorder, and all forms of substance use are present. So although stimulant use is the most predominant substance use in our region, providers are acutely aware of what drug trends are in their region, and prepare for how to manage withdrawal and the comfort needs of participants. So, some more rural areas are stimulant focused, and there's a lot more poly or opioid focused use in St. Louis. Next slide. And looking at program outcomes, the overwhelming majority of participants were connected to a certified peer specialist for recovery coaching. And that would include, developing recovery-oriented skills like coping skills, identifying and improving on health and wellness activities, developing goals like, as big as getting a job, or just learning what situations trigger them to use. And as Rachel said, other services offered include getting them connected with things like IDs or setting them up on Medicaid, but also mutual help groups like NA or AA, faith-based and secular help groups, morning meditations, arts and crafts. One location in St. Louis is doing gardening and kind of beautifying the area around the facility and putting that energy into, making recovery physical and seeing that growth. Almost half were connected to other recovery support services external to the organization. Again, there's a lot of umbrella organizations that are able to feasibly connect within, but they have also integrated within the community and made connections with organizations that are not the same. Treatment, 35% was connected to MOUD and 31% was connected to primary and other health care. And treatment connections, are often dependent on what resources are available to locations and transportation to those locations. So thinking about our rural providers, it's something that they attempt to set up, but it might not be made in that time frame. But again, under the umbrella organization, many of them will continue on to other recovery housing or within that same org, and will hopefully set up for these type of services further on their recovery journey if it was not during their time at respite. Next slide. And, since the primary goal is crisis stabilization, we wanted to focus on housing as foundational to continuing on with long-term recovery. So it's really notable to mention that at discharge, 2/3 of participants moved on to stable housing, meaning their own permanent housing or recovery housing. And the percentage of folks unhoused at discharge was reduced to only 7%. Next slide. So, I shared outcomes from monthly data, which is just numbers and, a formulaic survey that everybody fills out each month. It doesn't really capture all indicators of recovery. So, I'll ask you, Rachel, what is not captured that you see as important indicators of recovery or stabilization?
Um, some of the things that we see could absolutely never be quantified, right? Like, how do you quantify the return of hope or dignity or somebody's personality coming back? And we get the pleasure of physically watching them come back to life. When they come through our door, a lot of times they're underweight, they're withdrawn, they don't necessarily make eye contact with you. We serve diverse populations from diverse backgrounds and different levels of use and drinking. So they present with lots of different things. But sometimes their world doesn't extend beyond getting through that one day, right? And then you start to see the little changes. They start eating regularly, they are putting on weight, their cheeks fill out, the light comes back on in their eyes. I know that you've all seen that. They start laughing and joking with the other participants and staff. That's kind of really when you know they're starting to get comfortable a little bit and feel better. Their posture changes, they start participating in group instead of just sitting slumped in the chair, barely listening. And eventually they start talking about the future. They start talking about their plans, where they might want to live, where they might want to work, maybe reconnecting with family. And we get the incredible privilege of watching that transformation unfold.
Yeah, that's really exciting. And, at a further state, what do you think defines success for someone who stays at peer respite?
Trick question.
Yes.
I would never define success for a respite participant. We all know success in recovery is incredibly individual. It's not a metric that we get to set for them. Each of them gets to decide what that looks like and especially how they want to spend their time with us. So very occasionally people walk in the door with a clear recovery goal. Maybe they want to enter or return to recovery housing. They want to reconnect with family, stabilize enough to return to work. They have that in mind when they get here and they tell us, right? But as often, or maybe even more so, participants arrive without any idea of what recovery could look like for them. Some of them have never tried to stop using before, and others gave up hope a long time ago. And when they've spent a lot of time not knowing if they're going to survive tomorrow or next week or next year, making a 90-day recovery plan is not what they start with. So sometimes the goal for them is maybe just a nap and a sandwich and enough time to get away from their drinking or using long enough so that they can control it again. I know that that was a treatment goal for me sometimes. We honor that and talk with them about safer use practices. We connect them with community resources where they can access clean supplies. We make sure that they know where they can get help. We provide them lots of naloxone and give them our number so that they know that they can call us back whenever they want to or need to. And sometimes they decide for the first time that they want something completely different for their life, and they're in it to win it. They're in there for the long haul. And our job is never to decide which one of those outcomes counts as success. Our job is just to listen, let them tell us where they want to go and what success looks like for them, give them safe place, time and support, and as many tools as we can to help them get there.
Awesome. Thank you so much, Rachel. Next slide. Thank you. And yeah, so thanks for sharing all of that, Rachel. And I also got a chance to speak to some of the former residents about their experiences that are immeasurable in traditional quantitative data form. If you could go to the next slide. So as we mentioned, we are in the process of interviewing former participants at all 5 locations. We are doing 18 virtual 60-minute interviews, and participants are compensated with $50 gift cards for their time. As we're still in the process of conducting the interviews, the formal qualitative analysis is to come. But on the next slides, I'll discuss some initial facilitators and barriers to respite on being a successful intervention. Next slide. So something that came up consistently, almost all of the participants reflected on, one of the things that was beneficial and important to peer respite was peer staff practicing empathetic service. They know that the staff were sometimes maybe where they were, hit that place in their journey, and they have that empathy and patience to welcome them in, even if it's their second or third go around. One participant even mentioned that he overdosed during his intake, and of course, he was given naloxone, stabilized with emergency care, and they let him in to return. It was not a disqualifying event. It was something that they knew that they needed to support him and welcome into this program. A welcoming, non-coercive environment and autonomy. Recovery is self-guided, and groups are offered to stay engaged and promote recovery, but they're limited in quantity and length, and there's a diversity of offerings, and there's no one way to engage. And folks are still welcome to return if they discharge, under most circumstances, and they say that they do because they don't feel judged or punished. And it's based on this internal readiness that they are trying to start again and know that they'll be welcomed back. Again, with this community and positive relationship among residents, there is the social model of recovery similar to recovery housing, but just in a more formalized environment with staff 24/7. And participants are hearing about respite from others, so it's building community inside and out. And structure and routine as stabilizing forces. That is something that after a few days of acclimation, having your basic needs met, respite provides structure support through planned groups and meals and activities that start to prepare them. And removal of basic stressors is really important. We think about like the hierarchy of needs as essential to succeeding long term. And so by having your shelter, your food, your basic health and wellness needs met, it allows someone to actually stabilize and come out of crisis and chaos, start to look at a longer timeline of recovery. And so we just have a few quotes from these participants. If you could go to the next slide. We've also identified some potential barriers as having all of those in early recovery entering peer respite. Community awareness is still building. Again, it's every year over year we are increasing how many participants are entering through the door. But some mentioned not even hearing about it before and were connected just for the first time after struggling with years of substance use. Lack of capacity, everybody knows that is a struggle in all sorts of fields, and growth is limited by bed and staffing capacity, but providers do work on bed turnover. So like we mentioned, 75% are leaving after 20 days. And so providers are really working to get someone stabilized, planning for discharge as soon as somebody seems, well enough and stable enough to graduate so that a bed can open up for those in more delicate, more rougher states that might otherwise not have a door to longer term recovery. And so pushing them through into, or not pushing them, but encouraging them and facilitating them into recovery housing, whether it's in their own organization or in the community. That's what they're encouraging to do and making those warm handoff. And again, it's the internal readiness. It's something that had came up a lot, but it is a subjective feeling that can't be prescribed or dictated as something that a provider can have. The internal readiness is you have to want it more than they actually want it for you, honestly. And so that's something that folks mentioned as, if they had to return again, or if they knew of somebody who didn't, you know, or if they didn't succeed at peer respite and had to return again. So, yeah, I will close off that and hand it off to Maria to wrap up. So if you could go to the next slide, please.
Thank you, Lindsay. So to close, we want to bring this back to a few takeaways on what we've learned so far and where we still have questions and opportunities to learn. So next slide. We don't want to overstate or oversimplify that we've figured this all out, or that this is just a simple formula for operating a low barrier model, because it's very complicated. It's inherently challenging, and we're learning across all of the sites what works, where the tensions are, and what it takes to do this well. A lot of these tensions are still showing up in very practical ways, and we don't have clear consensus yet on best practices. So things like risk reduction restrictions, substance use monitoring, peer hiring and turnover, admission hours, referral pipelines and partners with traditional and untraditional partners and parts of the system, and types of structured programming. One provider shared, everything swings toward more structure. It graduates toward that more and more, right? Which is why you just end up having a machine. And so that's why I think that it's more difficult to do, but like as much autonomy as you can, man. I mean, that's what's going to work. That's what folks are going to come back and be like, man, this place is amazing, right? Not like, God, I had to do all this stuff. So we're committed to learning what the needs are to be flexible, what kind of input and support and resources it takes to really do that. So we can ultimately kind of build a model that is both effective and scalable to other states and communities. Next slide. And so overall kind of implementation, we are really proud that we feel like this pilot is operating successfully across diverse communities. There's a strong community acceptance and engagement, showing consistent and growing referral volume and demand for an intervention that really meets these needs of folks in early recovery. And that this kind of model of continued collaboration with state partners, local providers, and us as evaluation partners has kind of supported this implementation and expansion. We are, as Lindsay said, finishing up these stakeholder interviews, and we're hoping to do future analyses that will look at the longer term outcomes and program impact. And then finally, sustainability. So long-term sustainability remains a key challenge. We all know funding is always uncertain, especially now. And because this is non-clinical and the programs do not have like a fee-for-service or billing model, that creates risks for program continuation. So identifying sustainable funding strategies is going to be really critical as we keep developing out this work. And so one last time, I'm going to turn things to Rachel. So Rachel, first of all, what do you think is most important for funders, policymakers, or healthcare systems to understand about peer respite?
I think the most important thing is that a dollar spent on respite can represent many more dollars saved elsewhere. So respite, comparative to other solutions, right, is relatively inexpensive. Emergency departments, inpatient hospitalizations, incarceration, and repeated crisis interventions are way more costly. If we can give someone a safe place to stabilize and keep them from an unnecessary hospital stay, that's a savings. If we're diverting someone from repeatedly using the emergency department, like their doctor's office, that's a savings. If we can intervene before someone's crisis results in involvement with law enforcement or jail, that's a savings. And I also think that there's an opportunity with healthcare systems and with treatment centers to recognize us as a resource to help them use their services more effectively. If their residential treatment beds are full, but maybe someone could benefit from partial hospitalization, or they're enrolled in IOP but can't attend consistently because they're sleeping somewhere different every night, or their current living environment makes it almost impossible for them them to stop using or drinking. In either case, they could stay with us while continuing to participate in the treatment program. So the billable services continue, whereas otherwise they don't. So the cost of a respite bed is a drop in the bucket in compared with the other healthcare costs that we can prevent and the treatment opportunities that we can help make possible.
Definitely. And then finally, I'm going to combine the last two questions. So what advice would you give to communities or organizations interested in starting a peer respite program? And paired with that, looking back on the pilot, what are you most proud of?
My biggest piece of advice is love the problem, not your solution to it. If you become too attached to what you think peer respite is supposed to look like, you miss out on what the people you're serving actually need. Respite is not a one size fits all because the people who walk through the doors are not one size fits all. It's intentionally broad and low barrier because we're trying to create space for many different people, goals, and outcomes. And you have to be willing to change. Lindsey mentioned earlier the example of us trying to go non-smoking. We wanted to be completely tobacco free, and I loved that solution. It addressed a lot of health concerns and solved so many logistical problems for us. And I used to be a smoker and I'm not anymore. And the smell of it is just, it's hard for me, right? And I love that solution, but our participants did not love it. Some of them genuinely tried nicotine replacement because they wanted to stay with us. They wanted respite. They wanted to give it a try. But ultimately they would end up leaving because they just wanted the cigarette more. Others wouldn't come at all. And so eventually we had to acknowledge that a policy that we thought was beneficial was actually creating an unnecessary barrier for the people we were trying to serve. So we changed it. And we've done that over and over and over again. When we first started the pilot, before that, we didn't even have a name for what we were trying to do. We just knew that we wanted to do something differently. We wanted to serve everyone, regardless of their length of sobriety. And we didn't believe that a recurrence of symptoms of someone's disease should automatically mean losing the roof over your head. So we initially tried providing what we began calling respite within our recovery houses as part of the level system. If you came in and you had just been using, you would be on respite when you first got there. Or if you'd been with us and you had a return to use, you'd be on respite. But then we connected with DMH and we received funding and were able to partner with them and had the opportunity to take it so much further. We eventually moved respite into its own building and made an entirely separate program with 24-hour staffing and all-inclusive needs provided for. The program that we operate today looks nothing like where we started. And honestly, that's what I'm most proud of. We didn't build something and start it off and then spend the next 3 years defending it. We kept listening. We've learned from our participants, our peers, community partners, researchers, government agencies like DMH, and each other. And we're constantly asking, how can we do this better? And if you could change one thing, what would it be? We have suggestion boxes all over the building. We have collaborative conversation with our participants all the time. Recently, they were like, all of our snacks are sweet stuff. Okay, well, we got them, little fruit cups and more cheese and crackers. And I know it seems like a small thing, but it's really about serving them and being willing to change and try new things. There was absolutely no rule book when we started. We just made it up. And we're still making it up as we go. But we're doing it collaboratively and we're never so committed to what we think is best that we stop listening to the people that we're here to serve. So that's it.
Very powerful. Thank you.
Well,
And so, I don't know, go ahead.
oh, Maria, did you have more? Yes?
No, I was just going to transition to you. So thank you.
Okay. Well, thank you for that excellent presentation. And at this point, we want to open up for the audience members to ask their questions about the specific program or the recovery housing literature in general. So right now, the participants can raise their virtual hands or put questions into the chat. Or yes, I see a hand. Friedner Whitman?
Yes, can everybody hear me all right?
Yes.
Hello? Yeah, okay. I'm gonna, yeah, well, this is wonderful. I've been in the sober housing field since the late 80s, early 90s. I'm very excited by what I'm hearing. But I'm also having a deja vu all over again feeling. And I have some questions, some historical questions for you. First, are you familiar with something called the California social model recovery housing approach? And does the name Ken Schonlaw ring a bell with any of you guys? Secondly, I'd love it if you could talk some about architectural aspects of your housing design. My basic trainings as an architect, I've been involved in the design of sober housing for this last 40 years. And I see a lot that I like, and I also see a lot of semi-institutional stuff, which seems to blend together very nicely with your mission. So I'd like you to discuss how you're getting the architecture to work for you. And then finally, I'd like to ask what kind of reception you're getting to housing in your community from officials, like particularly planning zoning officials, neighbors, the folks who are always going after somebody's going to live next to me who I don't like and I don't know, and they're going to come and do some bad things to me. And, how do you deal with neighborhood issues? And then I had one other question that's slipping my mind, but let's just start with that. Okay.
Thank you. We appreciate that. I'm going to try to triage this a bit. So I think for questions 2 and 3, I would love if maybe Rachel could jump in and share if, if there are any architectural things, of note, that are maybe different from some of your other sites or work well for your peer respite site. And then if you have what the reception has been like in your community and if there has been positive or negative from neighbors or the broader community. And then I'll swing back after that to the California social model if we have time.
Sure. So our respite center differing from our regular recovery residences. I think key thing of note is that this building is zoned commercially, so we're not subject to some of and that's probably unique to us. I don't know how about the other providers in the state. I can't speak to that. So our building is zoned commercially, which gives us there are some drawbacks to that, but it also gives us some freedoms that we maybe wouldn't have if we were attempting to operate under even fair housing, right? So we don't need that to cover us because of the fact that we're zoned commercially. And then the community reception has been pretty great. And we do experience NIMBY, right? The not in my backyard with our recovery residences, but with respite specifically, we haven't run into that too much. Structural differences. This building also serves as our office and our intake center. So we do have our offices here, and I would say that supports us because of the fact that we have 24-hour staff. So I've got a case manager in residence. I have an admissions and outreach coordinator. I've got a behavioral health tech supervisor. My office is here, and so it just provides that additional support. There are many people on site to help meet their needs on a daily basis, as well as we call them behavioral health techs, but they're peer support. They all have lived experience. They are all certified as peers. And their job is to work directly with the participants, provide groups and make sure that their basic needs are met. But then they also have the support of the staff that's here in residence. I would say that versus like home-like environment versus clinical, you saw some of the pictures. I'm not sure if you were saying that some of them look like they have clinical elements. To me, they look homey. We try to make sure that it is clean and bright, and without clutter, while also having a home-like environment, and home-like spaces. We have 2 different living rooms and a group room that is for their use, where they have access to the computers. And the kitchen is like a regular kitchen. We do have like a commercial-sized refrigerator, and so, but it looks, I don't know, it feels like a home to us. So. Did that answer the questions? Was there something else I was supposed to talk about?
Yeah, yeah, I remembered my other question. And that is, so could you discuss your relationship to AA?
We have people in the community that bring meetings in. So we work closely with H&I. But I would say, I think we have 2 different groups that bring in an AA meeting. We have a couple that bring in NA. We have a lady that comes in and brings in Bible study, because while we're not faith-based, we want to expose them to all of the different community options and recovery supports available to them. So my personal relationship is to AA is that I'm a big book girl, but we support all paths to recovery, and that's really true to our mission to make sure that we stick to that, and that we're focused on their physical needs and allow them to explore the spiritual options at their own pace.
Okay, and then I have one final comment, and that is this is deja vu all over again for me, because what you are describing right now is essentially what the Salvation Army Harbor Light program was doing in San Francisco during the 60s and 70s. It was serving exactly the same functions, namely serving as a node in the community to connect people out of their addiction or off the street into um, uh, better housing and services and so on to get them out of their lives. And I just want to mention that I know about sober housing and Harbor Light because I actually did some work with them back in the day when I worked for the NIMH people. And one of the graduates of that sober housing approach at Harbor Light ended up becoming the head of alcohol and drug prevention programs for Los Angeles County and did amazing work in converting the prevention recovery system in LA County to support sober housing and to work with Ken Schoenlaw and the California recovery model. So you guys are deeply rooted in the history of the evolution of sober housing. And in fact, the whole sober housing program, the Harbor Light, or the social model recovery program with Ken Schoenlaw has become NAR, the National Association for Recovery Residences. So you guys have very strong. I just wondered the extent to which you have you thinking about that history and that connection, and the fact that you are once again creating a positive node. The housing becomes a node in the community to connect people back into the community. So
Wonderful.
thank you very much.
Thank you for that comment. Paul Stevens.
Yeah. Hey, uh, I work for Oxford House, and I've done so for a really long time. And I will say that I just cannot tell you how great of an idea this is. I remember hearing about it about 4 years ago at an R conference, speaking of NAR. And I'm so thrilled you guys are doing this. I'm curious what has been your experience as far as interacting with recovery homes, with people that have to leave? Like Oxford House is a require. I mean, they're on that end of the continuum with no staff and not that kind of structure. They're obliged to expel people when they have a recurrence of use. Do you have experience with your operations there, taking people from recovery residences, whether it's Oxford or level 2s or 3s, after recurrence of use? Have they ever gone back to the same recovery residence? Or do they tend to then move on to some other housing option?
Is this me again? Okay, yes, that is a wonderful function of respite, and it's something that we love to do. We work really closely with the other recovery housing providers in our area, and we encourage them, don't discharge somebody to being unsheltered or to the streets, call us. We would love to provide them with a short reset. We will keep them for as long as the recovery house wants us to, if they want their participant back, right? So if that person is eligible to return, they can say, hey, we just want them to be there for 5 days, or we want them to be there for 14 days. And that usually depends on the severity of the reoccurrence, right? How long did it persist? How did it impact their mental health or their physical health? And they get to decide. Sometimes they send us somebody and they're not eligible to return. And so then we would connect them with another provider of their choosing when they discharge from respite. But we do work really closely with them, and we want them to utilize us that way. And we let the Oxford comes in and does presentations occasionally, and talks to our participants about Oxford. We have their stuff in our respite center too. We would love if the Oxford houses would call us instead of, well, as part of their discharge process to let us know.
I'll remind the field staff in Missouri about you guys.
That'd be great.
Yeah. Thanks.
Great. We have one more question from Carlos. It was in the chat. Maybe he's not here any longer.
Yeah, I think that we need to wrap up, Carmen. And
Yeah.
I encourage
Okay.
folks to reach out to our amazing presenters who provided their email addresses so that folks, if we didn't get to your questions, feel free to contact them through their email.
Okay, well, this is great. Thank you so much for a fantastic presentation, Rachel, Maria, and I'm and Lindsay, of course. So, all right. So we're going to move forward. We want to let you know about upcoming events. We will not be hosting a webinar in September. Our next webinar in October will feature Dr. Kelly Knight, who will present on overdose vulnerability and service needs among people experiencing homelessness. Now, in November, we'll hear from Brandon Bergman, who will present on multi-help groups and medications for opioid use disorder. So unless we otherwise advertise, the I-STARR webinar occurs on the third Thursday of the month from 11 to 12 on the West Coast and 2 to 3 for those on the East Coast. And you can register for any or all of the webinars we've scheduled on the I-STARR website. You can also stay connected with the I-STARR project through our social media accounts, which we have listed on the slide. So if you are on the I-STARR website, you can also see information about the I-STARR training series. So this training series is 12 webinars with separate training topics for recovery housing operators and providers, as well as those interested in doing research on recovery housing residences. So those who participate in all 12 webinars in the training series will receive a certificate of completion and be provided the option of being identified on the I-STARR website as someone who completed the training. So at this point, we've completed all the live trainings, and this has ended, and we can only track completion of the webinars if you register for the series and view the webinars on the I-STARR Learning Management System on the website. So if you have any questions about the training series or about how to complete it, please reach out to us. So I want to also mention the NCARS conference. Our next slide, please. National Conference on Addiction Recovery Science, which will occur on September 23rd and 24th. It's a virtual conference. Registration is now open. So we're running out of time, everyone. I want to thank you, Maria, Rachel, Lindsay, for an amazing presentation and everyone in attendance for their attention. We look forward to seeing you on October 20th. And enjoy the rest of your day. Thank you.